Welcome back, everybody, to our next session at Health Impact, a Power Pack panel talking about how we're moving from things that we've seen in the telehealth realm to really a comprehensive digital care strategy. And digital care and care by itself, without the word digital in front of it, is probably where we're really heading, right? I mean, this idea of saying that there is a physical care versus digital care, this should be quaint to us very, very quickly. And that's really what our panelists are going to talk about today. So this comprehensive strategy to make it in a post-COVID world, what do the foundations look like? And some of that foundation is technology, which we've seen, but that's almost always the easy part. The harder part is, are patients adapting well and reacting well to it? Is our staff ready to handle this more comprehensive digital plus physical strategy? Those are the bigger questions that are being posed now that we're 6+ months into the COVID era. And of course, there's a regular era, non-COVID kind of healthcare continues. People still get sick. They still have heart attacks. Diabetic patients still have diabetes problems. So that's all the stuff we're going to talk about today. So with that, I'd love to have Geraldine kick us off and give us a little intro, and then we'll get over to Tressa and Stephanie as well.
Thanks, Shahid. Thanks for having me. My name is Geraldine McGinty. I'm a radiologist by training. I specialize in breast imaging. I'm at Weill Cornell Medicine on the Upper East Side of New York City, and I serve as the Chief Strategy Officer for our physician organization.
Awesome. Welcome, Tressa.
Great. Yes. Good morning. And thanks. Thanks very much. I'm honored to be part of an esteemed group here with you this morning. I'm the Senior Vice President and CIO of LifeBridge Health, which is in the Maryland area. And appreciate to learn with everyone today and share my own perspective.
Awesome. Stephanie?
Yes, good morning. Also really excited to be here with this great panel today. I am Stephanie Lahr. I'm the CIO and CMIO for Monument Health in Rapid City, South Dakota. We're a not-for-profit healthcare system serving most of Western South Dakota and a bit of Eastern Wyoming and Northern Nebraska. I'm an internal medicine physician by training, but pretty much spend all of my time in informatics and technology these days.
Excellent. So yeah, I think we're going to have fun having this conversation. So there's a lot that's been going on, and whether it's from telehealth or other changes, what I'd love for you guys to comment on first. And Tressa, since you're a neighbor of mine, I'm in Silver Spring, you're up in the Baltimore-ish area. We'll start with you. What have you seen that you think is absolutely going to stick going forward in terms of the change in the dynamics of what care delivery organizations like yours are going to do in the future, and what looked like it was going to stick, but maybe not what we've learned in the last few months. So for example, telehealth shot up, but then now is coming back down probably a little faster than we thought it would. Is that correct? Is that what you're seeing as well? So what do you think sticks long-term and what doesn't stick long-term from your perspective?
So what sticks long-term, and we've talked about it a lot, but this recent pandemic brought it forward, is the importance of choice. When we talk about multifactorial ways of interacting with each other, a lot of it's about personal comfort, and we need to offer choice, and choice needs to be reimbursed as long as it's clinically appropriate, and everything else follows. So very similar to what you said, we had an explosion of telehealth, and we've seen a bit of a bell curve that's happened. And what is very obvious is it's here to stay, because for many of the patients and communities we serve, it's their preferred mode of communication, but not always. So, we've talked a lot about personalized medicine and having therapies that are appropriate for one's genome. And I think we need to just understand that patient preference is going to stick too, and that it's not a one-size-fits-all. What I may want for my GYN care is different than for a specialty situation, is different for my child in an urgent care environment. And the understanding and the management of those consumer preferences in healthcare are here to stay, just like they are with our Amazon purchasing profile.
Yeah, that's such a great point that you've made, Tressa, because if you think about personalized medicine, so much of that is tied to the choices and preferences that we're talking about, do you feel, Tressa, that is LifeBridge ready for that level of preference management, choice appropriately being offered, and tying that to the personalized care? Or is there still a ways to go because the tools, the technologies, the approaches don't really exist and we're still kind of like muddling our way through it?
I think many of us have made early investments in CRM tools, but we certainly have not exercised them from a technology perspective in the same manner that organizations that are or have been more consumer oriented have been and have invested. But we also have to remind ourselves, and I know the clinicians here on the panel will remind me as well, it's got to be a blend, because just because it's preferred by the consumer doesn't mean it's the most clinically appropriate. So there's got to be a balance there. And yet again, like other things in healthcare, it's very much like other industries, but, and that's the but. The but is that consumer preference can't trump clinically effective care.
Mm-hmm. Yeah, excellent point. Geraldine, you've seen this as well. So why do you believe that just as an example, the telehealth side, shot up and now has it come back down? Is that a natural thing that's occurring because organizations are now bringing patients back to non-telehealth? Or do you think it's the patients that are seeing that, telehealth is great for certain things, but like Tressa is saying, something that's it's not so good for? So where is the tendency to bring it back? Is it coming from the patients or from the institutions?
I think to Tressa's point, it's a combination of both, and we're seeing very different telehealth rates across our departments. Psychiatry is still seeing the majority of its patients via telehealth. Primary care is doing a nice mix. And then there are other specialties, some of the surgical specialties, especially because they're dealing with some pent-up volume, that are really, seeing the majority of their cases in person. I do think it may be a little early to think about where we settle out, because some of the uncertainties about reimbursement, that was a big barrier pre-pandemic to us really going full throttle on adoption. Right now, we're still under the provisions of the various states of emergencies. What happens, especially with commercial payer reimbursement, I think is going to significantly impact how we settle out.
Right. And what do you see? What's the writing on the wall now saying on the payer reimbursements? Are you guys feeling good from the care delivery side that they see the benefits and they're going to move to better reimbursement? Or do you feel like they're kind of biding their time and they're not really going to reimburse in the future?
Well, one of my other hats that I wear at Cornell is I lead our negotiations team, and we had some heterogeneity in terms of whether we were getting reimbursed, and specifically we had payers who were using national networks, not allowing our physicians. And I do think there's been a recognition that there's a real value to a patient seeing their own physician who has access to the electronic health record. I'm fully expecting some pressure to discount those rates based on a perceived reduction in our cost base to deliver the services.
Yeah, that makes sense. And Stephanie, talk a little bit more about the broader aspects of what stays and maybe what does not, because we know that we've learned a lot in the last 6 months about what hospitals and health systems can do, small, medium, large, that we didn't actually know that they could do before. Like you could do things much faster, you can do more of them, the patients are more adaptable to change, workforce is more adaptable to change. What have you seen, and even broaden it out, and we'll bring Geraldine and Tressa to offer the same broader context, is what else is likely to stick just because of what COVID has done that you see as beneficial?
Yeah, I really love that question. I think we've all grown in our perspective on how we can accomplish goals, how we can tackle problems organizationally. Most of our organizations are large enough that we've always had to have pretty strong governance processes. In fact, many conversations at forums like these have historically been about governance. How are you creating governance? How are you sustaining governance? How are you building the right governance? And for a time there, governance went out the window, right? we didn't roll out telehealth in 3 days by going through all of our governing processes. We said, this has to happen and we got to do it now. And so I'm going to make some decisions. You're going to make some decisions. We're going to do this and we're going to get it in. neither of those are probably the ideal, right? We probably were a little too slow in our processes, a little too much bureaucracy in making things happen before, but we can't function on crisis mode and do everything in 3 days forever. And so I think right now we're really trying to figure out, how do we blend those so that we can be more agile and facile, knowing that we can do it. We at least now have the experience in the rearview window of saying, we can do this. So it's not a matter of if we can, it's when is the right time to be more agile, when is the right time to work with more governance and have to bring people together. So I think that's one big part of it. And then I think it's there's also a lot of shift, I think, in the paradigm around how we work with our workforce that has changed a lot. And for a time, I think there was a thought that, again, everything was short term. We were going to send our workforce home for a little while. We were going to bring them back and everything would be back to the way it always was. Now there's that question, and I think this is an interesting choice question as well. We're talking about our patients and the choices that they want to have. I am thinking too about my workforce and the choices they want to have. They're working from home. We have new complexities in our school systems. Our culture is very dependent on our school system. I mean, our whole world for many in our workforce starts with, well, where are my children during the day and what are they doing? And then we sort of work our work life around it. So I think as those things are changing, I'm also thinking to myself, I think my workforce could probably be 90% off-site forever and be really effective at that. And some of them really want that. At the same time, I have some people dying to come back to a building full of people where they can interact and be social. And so then the other thing we're working on is, well, if that's not going to be possible for a while, what are those new tools or that we're going to continue to use or expand to go from kind of crisis mode socialization to things longer term?
Yeah, I love that point. You never thought that your children's schools would drive how workforce planning happens at hospitals, but you're so right. I mean, so many of us at hospitals are family folks, which is perfect for our workforce. But that then drives that strategy. So when you look at governance, one of the reasons for governance is that health systems are very permission-oriented and consensus-driven. So Tressa, talk a little bit about how much permissions orientation have we learned is not actually necessary. Like, you don't need to have top-down permissions for all of the major actions that occur in a health system, and how much consensus-driven things that we do is still necessary going forward. Is it the majority still needs to be consensus, or majority not? Just give some color commentary, especially to the entrepreneurs and the people who build these things and want to get it into your hospital. How does governance work going forward?
I'll respond in two ways. And I think actually both my panelists spoke to this a little bit. I don't think we're going to go back. Well, first of all, the two influencing factors here, I think, are culture and timing. And so all of us exist in very different cultures. Organizations have very different cultures on the risk spectrum, so to speak. I happen to be in an organization that prides itself on innovation. So I oftentimes am frustrated because I feel as though we need more governance, not less. I've been in other organizations where governance was fantastic, and I could always brag about how well structured and clued in and pervasive and heterogeneous our governance was, and it took us a long time to get anything done. So I think, one, there's this cultural idea of what's the appropriate balance in your own organization on that risk spectrum. And, as mentioned, we haven't seen clear this crisis yet. And when you're in crisis mode, you're really down to just tactical execution. And as we, at some point, especially as executives, we need to start stepping away from that, because when we're all involved in the order of the day, we're not thinking about what's over the hill and tomorrow. And so, you know, that's a trade-off. If we as the executive team aren't anticipating 2 to 5 years out, no one's doing that, and that becomes a real problematic situation for the long play of the organization. So my response to that is, I don't know. I think we haven't seen clear to see exactly what it will do. Certainly a crisis proves what you can do in a short period of time, but it's exhausting, and you can't live in that mode forever, because it will be at the expense of kind of the long-term visioning, strategy, and direction of an organization.
Yeah, and what's interesting is I mean, all three of you mentioned that we can't do this forever. It's not sustainable, but I'm not quite sure if that's actually true. If you think about retail, they're running crisis mode all the time. Media industry runs in crisis mode all the time, and they adapt to it and they live with it. So I'm not saying that we should run in crisis mode. We're just saying parts of what we think are crises in healthcare may not actually be crises. They're like, I don't need to have permissions to do everything in the organization. If things are going to harm a patient, you have patient safety issues, you have patient welfare issues, those require a rigor that no other industry in the world matches, no question about that. But that's not every decision does not need to be there. And I think in this area, Geraldine, I'd love to get your thoughts on, just a comment out on that same thing is, when should permissions be necessary? Is it just patient safety, you know, in those kind of areas? Or no, the permission-driven process in a healthcare organization protects it. You have a lot of legal obligations, regulatory, compliance obligations, et cetera. So Geraldine, am I crazy in thinking that we can reduce the consensus requirements and keep permissions, or vice versa? Or is there a way of learning from this crisis that we could change our governance strategy for some major comprehensive care model improvements?
You know, I watched our organization learn mid-March, you know, as we went into really what was an incredibly challenging time. And governance obviously was critical, but we're a heterogeneous organization that has critical access hospitals, academic hospitals, and we didn't really know what was going to come one day to the next. So I think what we had to do was we had to learn together. What I think our organization did incredibly successfully was, you know, amplify the communications in a way that we had never done. You know, the CEO of the hospital system is broadcasting to the entire organization twice a week, but sitting with, you know, other experts in the organization and acknowledging the uncertainty when it's happened. Remember, we didn't have enough PPE at the beginning. We had to make decisions that undoubtedly people disagreed with, but I think we also had to keep reinforcing the shared vision. We also are in a city, New York is a city of many, you know, of was it 9 million people, all of whom have an opinion and are not shy to express it. So as we made decisions, we didn't make those decisions just in our health system. You know, the temporary decision we had to make that women would not be able to have their partner in the delivery room, that's something that the whole city had an opinion on, the governor had an opinion on. So I think that what underpinned what I think was an incredibly successful response was communication. You know, I think that will continue to inform how the organization functions. We will not want to roll that back. You know, these are not yes or no decisions. We shouldn't make them in a hierarchical way. We should have that kind of communication, and that should stick.
Yeah, that sounds great. And Stephanie, as you think about, you know, what we expand on or versus we contract on, let's talk about the comprehensive nature of care delivery in each one of your organizations. Are there any major paradigm shifts? And I think the one that comes to mind specifically is mental health. It looks like the mental health shift is probably the most profound that was likely to stay in this remote-ish kind of fashion more than anything else. Surgery will most likely come back to normal, whether that's months from 3 months from now or 9 months from now. That part of the world will look roughly the same. So talk about some of these specialties, and do you see any major paradigm shifts that are opportunities for strategic thinkers like yourself to start doubling down on, or is it just way too early, right? These are not really paradigm shifts. They're just new stuff we're learning. But tell us what you're seeing that might be a paradigm shift.
Yeah, I mean, I think you're right. Mental health, psychiatry, I think a lot of the intellectual specialties where we know and we have had really difficult constraints around the availability of those kinds of providers, is a real opportunity for telehealth. Because if I can be, for example, a psychiatrist in New York City and perhaps do have room in my panel to take on additional patients, and those patients can be in South Dakota and I can be reimbursed for that, that works well. And my patient can have that great experience. And if in South Dakota, I can't get psychiatrists to move here, to come here, to practice here, that really expands the offering in, again, those more intellectual specialties where it's mostly about the conversation between the patient and the physician, where there may be some elements of, physical exam and things like that, but we're even finding ways that we could potentially, alter how we do that. So maybe they go to a primary care physician's office and have some guided exam or other testing done, which is then provided to the specialist who is somewhere else. And in rural healthcare, we've been doing that for a long time, whether it was on the phone or using a camera or whatever it was, because you often do have, for example, a family practice provider at a critical access hospital 250 miles from anywhere, that they have in their lap what they have in their lap, and they've needed that expertise. So we found ways to sort of be able to do that. But I think that we have critical shortages in lots of our specialties, and that's probably going to get worse and worse. For those that we can, I think there is real opportunity, and we're seeing some of that now, where our patients can receive that care from somebody who may not be local if that's not available. But again, we're going to have to really pay attention closely to how reimbursement and licensure works, because of course, as of right now, in most instances, you have to have a license in each state that you want to practice, and licensure is not a process that takes 45 minutes. In fact, sometimes it takes more than 45 days. And so those are pieces we're going to have to walk through, but I definitely see opportunity.
Yeah, and that's actually a great idea. So when you think about it, Tressa and Geraldine, so Stephanie's got in South Dakota, normally it would seem like she would have to do a negotiated deal with either the self-funded employers or payers, and then the payers and others build the network of in a variety of different states and localities. Does it make more sense that going forward an opportunity is for, LifeBridge to have a direct deal with, Stephanie's facilities in South Dakota, so that when Stephanie has a need, she just goes straight to LifeBridge. She doesn't go to her payer, which then finds somebody in a network. Is that a new opportunity that now that specialties can be remote? When you're not a competitor in your locality, I think there's an opportunity for health systems to start coordinating and working with each other in different provinces, states, localities. How much of that is useful to think about, Tressa, at this time versus there's a whole bunch of other things to think about? That kind of opportunity is not that great at this point.
I think we've seen non-traditional models at our door, and this has liberated a lot of opportunities for us. It's liberated a lot of opportunities for very non-traditional healthcare providers. And so I think we need to be thinking very differently and along those lines. I do, and we've had a lot of those discussions. For those of us that have selected healthcare as our passion and our purpose and the industry, it's really about maximizing the talent of our care providers with the needs of our patients and communities. All of these artificial barriers, whether it's reimbursement, whether it's geography. I think many of us are committed, even though certainly competition still exists. There's there's shortages on the supply side for sure. And, it's a shame that we've got to navigate the complexity for that. So I think we need to be prepared to be thinking very differently about it. But at the end of the day, to me, it's still about maximizing our dear and short supply clinical assets with the growing needs of the community. And everything else in between is a bit of a distraction and a challenge to be tackled for sure. But, whether it's organizational agreements whether it's the ability as providers do now to practice in various areas. You know, I think the bigger danger really is going to be about imbalancing convenience with appropriate care. And, you know, consumers are going to go seek quick care from non-traditional settings if those non-traditional settings come about. And there still remains value in continuity of care. And if digital can help us with that, if it can help us make sure that patients get continuity of care irrespective of geographical location, so they don't feel they're being passed from site to site and clinical team to clinical team. Again, I think that's a bigger risk, as these more retail-like operations have every opportunity to join us in this space.
Yeah, to me, that's the biggest opportunity, is that thinking that health systems competition is another health system is silly in this day and age, right? The competition is really the pharmacy down the street. It is the national telehealth provider. And as you think about these areas, the other couple of areas where it seems like there's enormous opportunity, and Geraldine, just from your radiology side, I'd just love to hear what you're thinking in terms of two areas. One is radiology and the AI capabilities of image analysis, et cetera. You guys are already leaders in that field. You know, you do a lot of automation there. So I'd love to hear what is the state of that art. And given that you're so good at that, should, let's say, Stephanie's facility or other hospitals just take their departments and hand them over to you guys, right? Just does that make sense in these kinds of environments where an entire department, like a radiology department, in theory, I mean, we've seen this through Nighthawk Radiology and others for decades. So this is, luckily in the radiology industry, none of this is new. And we've had remote radiology, remote reads, remote consults, et cetera, for many, many years. What did COVID change in that area, if anything, and what sticks on these radiology departments?
Well, I think, you know, and I'm putting my president of the American College of Radiology hat on here. You know, we came out very quickly to say, imaging screening for COVID, don't do it, not safe, and oh, by the way, stop doing routine imaging. So I think, you know, what we did was we focused on the core values around appropriateness. And I think that, you know, as we think about, you know, making it easier to access care, I think we really do have to think about this issue of appropriateness and make sure that, and that's the value, I think, of having the on-site radiologist who knows the community and also who knows the entire spectrum of what we offer in imaging, because we are, especially in a center like mine, we're very subspecialized, but especially as we see more advanced practice providers in primary care who we know order more imaging, how do we support them and how do we support their health system in making sure that we're driving appropriate imaging and also managing costs, right? You know, imaging has been a major cost driver for many health systems. So how do we manage that? I think the other thing, just to talk about as we think about expanding digital access, is to have a very clear focus on making sure that we are doing that in a way that reaches populations who've been traditionally underserved by our healthcare systems. And, you know, we can all chase the digital natives who've got, you know, multiple smartphones, but how do we get to the people who don't even have a data plan or who have very poor Wi-Fi or no Wi-Fi at all? So I think that's something that we've really been focusing on to make sure that we don't leave them even further behind in terms of their access to high quality care. Yeah,
and Stephanie, this is an area which, of course, you live daily because you're in a smaller town environment, and then, of course, you've got a lot of rural. So there are two special areas that I think we could talk about here. Is one is pediatric care in specifically, and then family care in general. When you look at it from your vantage point in a smaller community, what have you guys learned about this rural and small community type of care that others can learn from, especially in terms of full total family care, as well as especially pediatrics in an environment in which not everybody can come in all the time? It's not like kids aren't getting sick. It's not like kids don't need that care anymore, but they're just not able to come in. Does that mean that things like Geraldine is saying get worse? Is that in environments that were already difficult to get care in, it's now even more difficult and gets worse? Or does COVID provide an opportunity to say, hey, now we have new ways of getting even better care than we did before in these traditionally underserved communities?
So I'm probably going to give you an answer that maybe is different or not what you're really wanting to hear, but I'll tell you that, here, Geraldine touched on some stuff that's very, I'm really passionate about. We have a very significantly, some underserved communities, some challenged communities. Our Native American population has a lot of socioeconomic challenges and disadvantages in being able to access care at any time, let alone right now. And on top of it, geographically, I always joke, I don't let our physicians do telemedicine from home because half of them live between two slabs of granite. And so I literally cannot get them the bandwidth that they need, let alone our patients who don't have, that are on 3 megabit per second DSL if they're lucky, or where they live, it's only satellite, and they probably can't afford it because it's $80 to $90 a month. So I will be honest, telemedicine for us did a much faster up and back down than it probably did anywhere else, I think for a couple of reasons. One, geographically and socioeconomically, it didn't fit a lot of our patient population, particularly since we also had to ramp it up so quickly. We couldn't really account for in rapid speed, how were we going to address those things? So now we're trying to take that step back. The great thing in small town communities like many that we serve are that there is that long-term relationship. And so a lot of our telemedicine ended up by telephone, no video, no any of that kind of stuff. But Dr. Brown knows you and your kids and your mom and your cousin and your spouse and the whole place that you work at. So she knows what's happening in your workplace because of things that are happening in the community. She knows what's happening in your kids' school because her kids go there too. She may have delivered your, there's this intimacy that does allow for care to continue, I think, in different ways, and also highlight some of the things that were said, that we don't want to lose that just because it could be more convenient to jump on a video visit or a telephone visit in the future. That intimacy in medicine is something that we're going to have to work to preserve as we try and find this balance. So I don't know, when it comes to taking care of the family, I've heard some great stories from other areas in the country talking about, that it really has made it easier for them. It's obviously difficult to pack together 5 kids, 2 of whom are sick, go to an office, sit in a waiting room with all 5 of them while you wait for 2 of them to be seen, and all those kinds of things. And so there's opportunity, small town, big town, whatever, to address some of those things. But I'll be honest, in reality, those are the areas where we're not seeing it stick super well. It actually is in, it's like some of the specialty areas like neurology and that kind of thing. Primary care, it's been more difficult.
Yeah, no, I think that
really gets to answer your question, but
no, it did. So Health Impact prides itself in being a no BS conference. In the last few minutes that we have, one thing I'd like to cover is this problem of misinformation. In the past, let's say about 30 plus years ago, the education for healthcare was often done in schools, a lot of times done at the local hospitals, at the local physician's office, et cetera. But we seem to have ceded all of that to Dr. Google, which looks like it's causing some of our misinformation problems. Is that literally, your local news station is supposedly now more of a expert than your local health department or your local hospital. How did that occur? Meaning the ceding of health education to Dr. Google or to news organizations, et cetera, instead of hospitals and health systems? Is it because of reimbursement or other things? Does that cause misinformation? And what could we do to help bring some of that back so that when our patients in the community need the best information, they get it from where the healthcare sources of information happen to be? So Tressa, we'll start with you. Let you make some concluding remarks around this major problem of misinformation, and then we'll go to Geraldine and then to Stephanie.
Oh, this is a tough one. When anything doesn't seem aligned, that's where I think it's important to start understanding causation. You know, at least in my own community, our providers are spending their day helping patients, not spending their day understanding the public health needs and communication for communities. In our location, public health is underfunded, and they don't have the same broad reach and ability that social or the media have. You know, these other industries that you focused on, Shahid, they're in the business of outreach and getting messages across, and yet apparently, from what you've said, they don't have the content expertise to do that. So, you know, I think it's a situation where there's a tremendous amount of information, right? It's complex. It's not always easy to understand. There are a lot of local generalizations that people make. You know, we all come to hearing a message with whatever our own background and preferences bring. So that just makes it more complex. So a lot of data, a complex message, and at least during the pandemic, a continually and ever evolving landscape and dynamic message. So I hear what you're saying. I just think it's a little bit misaligned from an incentive perspective. And I also think that it's just hard.
Yeah,
So,
no, I think,
you know,
and in the spirit of Health Impact being a no BS conference, that's okay. Is that you know, you're asking the health system to do things that it cannot do unless it is funded properly, unless the alignment is done properly. So this is really a lot, because you know, a lot of what the feds have done in the last 6 to 9 months have caused a lack of trust in venerable institutions like FDA, CDC, and others. So there's a paucity of trust in that area. Where is that going to flow back to? So where does somebody go if they
let me
don't
make
trust?
another comment, which in the recent years, excuse me, it's my observation that social media popularity has somehow translated into credibility. And that's a problem too.
Right.
You know, the sources you've cited, just because there are a lot of favorites because it was well said, doesn't mean it was truth. So I don't have an answer to this, but I don't disagree with your observations.
Great. So Geraldine and Stephanie, talk a little bit about this. You know, is misinformation anything that health systems could do about it?
I think we have to. I think I'll pick up on something Tressa said at the beginning, which is that we have to meet our patients where they are. There's no point in us having rigorous science on our website if our patients are getting their information on TikTok. And we absolutely need to find the way to get into that space. I don't think, to Tressa's point, that we can compete with the funding that organizations have, who are incentivized to spread misinformation, quite frankly, because it maximizes their return on investment. But we absolutely, I mean, I'm a breast imager. I spend a lot of my time talking to my patients about the science behind screening. That is part of the care that I have to give them. So I consider it to be part of the work that I have to do. We are up against formidable opponents, though, in terms of spreading misinformation. At Cornell, we're very proud of our alum, Dr. Fauci, and we're sticking with the science right now.
No, that's great. Stephanie, how about you, from your vantage point? Misinformation, a big problem, small problem? Anything you guys can do about it?
Yeah, so I mean, clearly it's a problem, and I think part of it is, and I don't mean this in a negative way about our health systems at all, but it wasn't a ball we had our eye on, right? I mean, we've had our eye on so many different balls. We weren't even really sure that was ours to need to have our eye on until it was kind of smacking us in the face. And then it was a response to, okay, well, wow, we need to do something different. And I know, locally for us, we don't really have any local public health entity. It really doesn't exist here. It's at the state level, there's something kind of, but at the local level, not. And people are looking to the health system to say, well, what does Monument Health think about this? What does Monument Health think we should be doing in our schools? What does Monument Health think we should be doing globally for testing? And because they actually want the information from us. we just had to find a way to be able to get our eye on that ball. And I completely agree with what Tressa said, that we're not necessarily incentively aligned to do that. But we're just trying to make it work, even if it's with, grassroots things that are simple and easy to do, radio, working with local TV and radio to do radio and TV spots with people like me or other, physician leaders in the community, giving a 30-second sort of little blurb out there, educating people. So, I don't think we're trying to, it's not a space that we want to compete necessarily in, but it is a space that we feel like we owe it to our community to do something. And it may not be the way those who are maybe trying to manipulate the market would be doing it as a part of their business. For us, it's really just more about the service. And this is something our community is asking us for. They see us as the leaders. We are the most knowledgeable. So we're trying to find a way to make those things work, again, whether it's techie or not techie.
That was great. So just in the last couple minutes that we have before we turn over questions to our audience, talk about any things that have happened in the last 6 months, year, 2 years, where you've got a crazy idea that you just love to try out, either at your institution or anyone else. Any provocative, crazy ideas that have come up where you think might work if somebody would just try it? Anybody want to jump in the last couple of minutes with that? Any other unrelated to this or related to this crazy ideas that you want to share with the community?
I'll just jump in and say, overnight in our organization, I don't have to touch doors anymore. I just wave my hand and I walk through the door. And I would love to see our technology, our electronic health record, our registration processes be that easy. I would love to never have to type a password again.
That's great. Luckily, that's not that crazy. That's just the ability for your senior staff to go make it happen. So that's good. Asking for an idea like that to say, wake up, give us two-factor authentication that's safe and secure quickly without having to type in a password. That's a doable one. Stephanie and Tressa, any crazy ideas?
I'll throw out, and I don't know that it's super crazy, but I'm not seeing it yet. So many other industries, airlines, I think, are a great one. The way that they're using automation, and we touched on this a little bit earlier, automation in the customer experience is a piece that I feel like I'm looking for tools that I want in this space, because again, I don't have all the people I need and I'm not going to get them. So how do I help people work to the top of their training, the top of their licensure, whatever that may be? I feel like automation is that. And I'm seeing there's definitely some marketed things in automation and revenue cycle and those kinds of things, but I'm talking about true patient-facing quality experience, automation technologies that could help us do more. I don't need to do more with less. I just let me do more with what I have so that we can sustain and build and grow, but create a good experience without having the solution have to be, well, let's hire somebody to do that. We'll have to bring somebody else in to do that. Let's make automation work. And I don't even know what all those areas are that could be, but that's a real area of focus for me right now, is how can I creatively think around that?
Yeah, that's such a great way of thinking about it, is that if a vendor or a solution provider comes to you, gives you a piece of technology, and then you have to hire somebody to actuate it, you've got a problem. That's a bad solution already there. So throwing bodies at the problem is what we've done in healthcare for decades. Those bodies are no longer available to throw at these problems because we have so many problems and not enough bodies. But the good news is that the capability for machine learning today, AI is a little bit more futuristic, but the machine learning parts, robotic process automation, et cetera, some of our partners at HealthIMPACT do support those kind of tooling. So where you have what are called digital twins, where like if every nurse had a digital twin, that would do all of the highly productive things that can be done without her having to type something in, that would be great. If you had another nurse and had a digital twin and he could get whatever he needs to get done because he got to automate it himself. Like, the power of Microsoft Excel or the power of Microsoft Word or Outlook is you don't need an IT person to go create a document anymore. You don't need an IT person to go create an Excel workbook anymore. that level of automation is still something that that we're begging for in healthcare. So the innovators in the audience, definitely listen to that advice and see if you can reach out to Stephanie with something where you can give her things where she doesn't have to hire anymore, but can get more done. So that's great. Teresa, you've got the last word here. Any crazy ideas or last minute thoughts you want to share before we open it up to the audience?
So I wouldn't say it's a crazy idea, but it's one that that is dear to me, and that is that our healthcare industry has automated from the inside out. You know, the health information on individuals is locked in insurance companies and hospitals and doctors' offices. And again, we saw what financial alignment did with telehealth and reimbursement and how it exploded. Today, many of us, based on preference, can either pay by cash, check, credit card, Apple Wallet, you know, etc. And, you know, I envision a day when our healthcare information is our own and we move from care setting to care setting, and we're the ones that are deciding and sharing with whom not only our preferences, but our information. So more from the individual into the ecosystem as opposed to the ecosystem out. So I look forward to that day. And I've not figured out the financial reimbursement. I think that's why PHRs died on the vine, because there was, you know, I'm sure the wealthy would pay for it, but the majority of folks in the industry have other people that help them with that. But to me, that's very transformational because it takes choice and really puts it on steroids. And at the end of the day, and certainly, you know, my clinical peers know this, it's not always about healthcare. A lot of it's about individual compliance. And if you're not meeting a patient, even if the clinical recommendation's appropriate, if you're not somehow meeting them at a place where they feel safe and it's of choice to them, if they're not compliant, nothing changes. So that's my big idea.
No, that's great. So just a quick note there is, of course, we know that the patient access rules from the ONC and CMS are starting to kick in now. With that, I'd love to open it up to questions now. Stephanie, thank you from Monument out in South Dakota. Teresa from LifeBridge in Baltimore. Geraldine, Weill Cornell in New York. And the panelists are yours to ask questions with. Thank you very much. You guys have had a pretty active conversation on the live chat at the same time. So before I hand you guys any questions, was there a particular one that you would like to answer off the chat?
No, there were really good ones. I don't know specifically. I will say one thing that I touched on, and Geraldine made the same comment. A couple of providers came to me and said, hey, they're not using very much telemedicine at all right now, but they said, hey, when we have snow days, we should use telemedicine. It was like they were having this major epiphany. And I was like, yes, we should. And we're working on that and looking at, you know, again, what are the logistics and how would we do that? Because now if you do have to be at home between your two slabs of granite that I already talked about and those kinds of things, you know, how can we make that work? But I do think that is a great example of people have expanded their toolbox. And they're thinking about new things that we can do, maybe not all the time, but using different things to solve problems that we've had for a long time, but with different things.
Yeah, that makes sense. So Geraldine and Teresa, was there a favorite question that you wanted to answer real quick before I jump in with one?
I thought there was a great conversation about how we're measuring our patient experience and how we're really understanding the patient's experience of care. We found our patients to be incredibly tolerant of sort of glitches with the telehealth platform at the beginning, much more tolerant than the physicians who were providing, who wanted it to be perfect. I suspect our patients are going to get more demanding about the experience. So I think understanding how we tap into how they're feeling about their experience, that may look and feel different going forward.
Yeah, that sounds great. And so if Teresa, unless you had a favorite question, I'll just pose one question, which doesn't get covered very much because we spend a lot of time on the remote stuff. But Stephanie and Geraldine, you guys talked about the ProCredX for the credentialing process. And I'd love for you to talk about why a tool like that is useful in general. That's nice. But specifically right now, as you have more access to more physicians from wider areas, how important is credentialing, and what is that tool, whether it's that particular one or anyone else, how does that make your life easier with respect to credentialing physicians to be able to do the telehealth and telemedicine that we want to do?
Well, I will say that one of the things we realized was that we had an issue with credentialing through Medicaid, which was on paper at the beginning, and we had a great collaboration with the State Department of Health to transition that to electronic. I think that the pandemic hasn't really changed that for us. It is electronic, but I do think, and we're working on a pilot with ProCredX. It's a big, complex process, and it's expensive for an organization, but we have to get it right. So how can we use tools like blockchain, and I'm not an expert, to take some of the friction out of that process?
Yeah, that's great. And Tressa, if you can make some comments on what are other tools that you guys need in order to enable all this extra remote and other care that is taking place. And you could comment on the credentialing one or anything else that you guys have been trying to evaluate to expand.
Stephanie, if you want, you can. I'm not familiar with the credentialing one. If you want to kind of round that conversation out, I just have no exposure to it.
Yeah, the only thing I would say is just knowing, I think blockchain, one of the comments that was made was, some of the power that blockchain will have in healthcare. And I think we've been waiting to see what are those use cases. And credentialing is a great one because it's information that doesn't change. It's needed by a large number of people. You need to have a really streamlined process for how that information was validated. But once it is, then it can be really, should be able to be easily validated and given to other people. So we've taken a process, credentialing and licensure are things that, like my credentialing, not very little of it has changed from the time I graduated from, have a little visitor, medical school and finished my residency. But yet every time I go to a new organization, I'm starting all over again. So it's just one of those things where it doesn't have to be as onerous as it is, and we're all spending a lot of time and money on it. Let's figure out a way to automate and or simplify it that we can all use. So I'm not specifically familiar with this particular one, but I think it's a great use for blockchain and simplifying things.
Yeah, we just needed to add that. And I'm glad that the question came up because there are lots of ancillary adjacency kinds of things that are needed in order to bring that up. Tressa, did you want to say any last remarks? Because I got the hook here saying we're running very late to get to the next session. Excellent. Thank you, Stephanie. Thank you, Geraldine. Thank you, Tressa, so much. It was a great panel. And of course, it'll be on YouTube for us to play again because there's a lot of good information in it. With that, everybody, please join us on the other session. Thank you.
Thank you.